So good morning, everybody. For those whom I haven't met, my name is Mark Dawidek. I'm one of the second-year urology residents, and on this snowy morning, to a decent crowd, I have the pleasure to present on the topic of adult genitourinary sarcoma. So these are malignancies that arise from connective or mesenchymal tissue, which is in contrast to the carcinomas with which we are more familiar with, which arise from epithelial tissues. A majority of sarcomas arise from connective tissue in the extremity or in the retroperitoneal space, and not directly from organs or visceral sites. And I'd like to just highlight early on that when I refer to genitourinary sarcoma, I refer specifically to sarcomas arising from the genitourinary tract, which is distinct from retroperitoneal sarcoma, which refers to sarcomas arising from connective tissue in the retroperitoneal space. So these are very rare cancers, and there's a dearth of information regarding their management. Fortunately, they share a lot of important biological features regardless of anatomic site. And so the treatment of and management of genitourinary sarcoma is often guided by the management of sarcomas at other sites. So with that in mind, today I'd like to cover some of the general principles of soft tissue sarcoma biology and management, and then review available guidelines. There are none specifically for genitourinary sarcoma, so I will cover our nearest neighbors, the retroperitoneal sarcomas. And then we will look at some of the specific literature relating to genitourinary sarcoma. And then I have an interesting case from our experience here at UBC. This is what got me interested in this topic. So just very briefly, when we looking at soft tissue sarcomas, that's non-bone sarcomas, they represent approximately 1% of all adult cancers, so they're rare to begin with. They do represent a higher percentage of malignancies in pediatric patients, but despite this predilection for pediatric patients, there is still an increase in incidence with age. They favor men, and obviously when we're looking at urinary sarcomas, that bias is going to be expanded, and overall they have a fairly intermediate prognosis. So a majority of sarcomas arise from de novo mutations in mesenchymal cells, and the pathogenesis is quite in line with the stem cell model of sarcoma cancergenesis. And this is broadly for two reasons. First, they arise in tissues with slow, if not even absent, cell turnover. And secondly, there's a high variability in histologies and even heterotopic tissue presentations. And by that I mean you'll see tissues which have no place being where they're found. For example, osteosarcoma of the kidney, so bone cancer in the kidney. The most notable risk factors are radiation exposure. About 1 in 1,000 patients treated with radiation will develop secondary sarcoma with quite a long latency period. There's also a handful of cancer syndromes which are associated with sarcomas, most notably Leiomyosarcoma with the classic p53 germline mutation, which is approximately 10 to 20% higher incidence. Interestingly, even amongst de novo arising sarcomas, there's a very high rate of p53 mutations. There's also the other one to note is retinoblastoma, again the other classic tumor suppressor gene, and these patients particularly have a high incidence of radiation-induced sarcomas. It's important to note as well that most benign connective tissue neoplasms, lipomas, leiomyomas, they almost never transform into sarcomas. So this is just quickly to highlight where our piece of the pie is in the big picture. So GU sarcomas represent about 2 to 3% of all sarcomas and less than 1% of all genitourinary malignancies. And once again, when we refer to GU sarcomas, we're referring specifically to the genitourinary tract and not including gynecologic sarcomas, though these both fall under the domain of visceral sarcomas. And retroperitoneal sarcomas are a separate consideration. It's interesting that these cancers are so rare that there was a recent European urology focus on rare cancers, which didn't even mention these rare cancers. They're difficult to treat, not only because they're rare and particularly at certain anatomic sites, but there's a vast number of possible histologies. So this is the World Health Organization 23 classification of possible histologies arising from various different connective tissues. There's easily over 50 illustrated here, and this doesn't include all possible sarcomas. For example, in prostatic stromal tissue, we can get a prostate stromal sarcoma. It's not listed here. It's kind of analogous to a GIST tumor, which is a gastrointestinal stromal tumor arising specifically in GI tissues. So as I mentioned, there's shared biology between anatomic sites, and this is because these histologies are often shared across anatomy. And in many cases, histology actually trumps the anatomy for sarcoma. So I'm going to focus on a couple histologies here, the liposarcomas, the leiomyosarcomas, and the rhabdomyosarcomas, and briefly discuss these histologies because they're the most common ones we see in genitourinary sarcoma. So liposarcoma, arising from adipose tissue, is amongst the most common histology, particularly in retroperitoneal tumors. There are 5 subtypes which are sort of classified into 2 sets of low-grade versus high-grade pairs. I won't dwell on the myxoid, round cell, and pleomorphic very much, other than to say that the myxoid, round cell liposarcomas are the most radiosensitive and chemosensitive of this group. But what we see predominantly in the retroperitoneum, including in the genitourinary tract, are the well-differentiated and dedifferentiated subhistologies. These are sort of the classic presentations, what we often think of when we think of sarcomas. They are large, locally aggressive, typically displacing or encasing surrounding structures, but not necessarily invading. They frequently recur, but rarely metastasize, and when they do, it's typically to the lungs or liver. Most of them are chemo-resistant, and they're intermediately chemo-sensitive. Typically, it's really only the dedifferentiated subhistology that will be treated with radiation. We rarely radiate well-differentiated liposarcomas. So across the top here, we have examples of well-differentiated liposarcoma. On the bottom, dedifferentiated liposarcoma. This is a CT. You can see that it's fat attenuation, and it's actually on imaging very difficult to differentiate from a lipoma. It's a round lobulated mass, and the subtle difference is typically these faint septations. And when we look on pathology, we see atypical lipocytes with these widened fibrous septa. On the bottom is the dedifferentiated tumor. And it's quite homogeneous. You'd almost think it's 2 separate tumors. You still see the large area of fat attenuation with these 2 solid lesions, which are the dedifferentiated areas. And the CT enhancement is not particularly specific to the underlying cell type. But it's almost a red herring, because when we see these masses, we often don't focus on the whole liposarcoma. We just focus on the dedifferentiated areas. And then when we look on histology, you can see these alipogenic areas of cells embedded within the lipocytes. The next histology I'd like to touch on is Leiomyosarcoma, which is derived from smooth muscle. Again, amongst the most common, including in the retroperitoneal sarcomas, but the greatest experience is actually with uterine sarcomas, and that's where a lot of the data regarding their treatment is derived from. Again, these behave as large locally recurrent tumors, but they do tend to recur distally and metastasize more often than the liposarcomas. There's no clearly established histologic subtypes. They can be difficult to differentiate from leiomyomas. And of note, just broadly, their behavior is a little more influenced by site of origin rather than just driven by histology. The role of radiation is unclear. In retroperitoneal sarcomas, they will treat with radiation. In uterine sarcomas, there's not a lot of data to support it. And the role of chemotherapy is largely derived from uterine sarcoma, where they will occasionally use gemcitabine and docetaxel. But again, a lot of unanswered questions. So on the top we have CT images of Leiomyosarcoma. It's a heterogeneous mass. It can be quite, those are CT images. It can be quite difficult to differentiate from, for example, a renal cell carcinoma. This is a retroperitoneal sarcoma here. And particularly because leiomyosarcomas can arise from vascular smooth muscle and invade intravascularly to form a tumor thrombus, so it can be particularly confusing. On the bottom are MR images, and it's hypo-enhancing on T1 and hyper-enhancing on T2, consistent with a solid muscle-derived tumor. And on histology, we see these fascicles of spindle cells, and on IHC, they're positive for smooth muscle actin and desmin. The last subhistology I'd like to touch on is Rhabdomyosarcoma, which is a little more rare amongst adults, but particularly well represented in the genitourinary tract. And it's actually the most common histology seen in pediatric patients. And however, the behavior is slightly different in pediatric patients. A lot of our treatment and a lot of the large trials have been conducted in pediatric patients, but in adults we see a significantly worse prognosis. These sarcomas behave a little differently from the others histologies in that we're usually able to attain good local control, but they typically metastasize, including to the nodes, which is actually quite rare for sarcomas. Sarcomas rarely disseminate via the lymphatics. They typically disseminate via hematogenous routes. The subtypes here are embryonal, alveolar, and pleomorphic, and these are not confined to the age groups indicated, but rather that highlights where the peak incidence is. And so these are, in pediatric patients, at least we found that these are radiosensitive and chemosensitive to regimens based around vincristine, dactinomycin, and cyclophosphamide, but that predominantly applies to the alveolar and embryonal subtypes, and pleomorphic are not usually treated according to these trials because they're quite rare in children and the trials don't apply. Okay. So I'd like to talk just a little bit about sarcoma management in general, and I'm going to frame it in the context of retroperitoneal sarcoma. Despite urologists not being the ones who typically operate on these tumors, they are in our so-called domain, and we're not infrequently involved in these cases, particularly for reconstruction. And there's even a chapter in Campbell's on retroperitoneal sarcoma. The other reason being is that this is, as I had mentioned previously, one of the only sites where we actually have guidelines. So broadly speaking, as I'd mentioned, retroperitoneal sarcomas arise from the connective tissue in the retroperitoneal space, not from the visceral tissue. They're characteristic for these massive tumors with frequent local recurrence. And it's often actually the local recurrence that drives the mortality, in that they eventually just become irresectable and invade into critical structures. The majority are liposarcomas with a significant number of leiomyosarcomas. So probably the most important principle for the general urologist in countering sarcoma is that all sarcomas should be referred to a sarcoma center. As we see above, the decisions regarding multimodality treatment are often considered on case-by-case across a spectrum of both histologies and anatomical sites. And experience with these previously is paramount. An earlier referral is actually preferable, even prior to biopsy, as sarcoma typically has specific considerations with respect to biopsy even. We typically image with CT or MRI with contrast. In the periphery, they prefer MRI just because you get the different planes. In the retroperitoneum, CT and MRI have been considered to be equivalent, but if there are issues with tissue delineation or characterization, MR is a reasonable addition, and particularly in the pelvis. And because these metastasize to the lungs, CT of the chest is important as well. PET doesn't have much evidence in sarcoma. With respect to biopsy, the core needles are recommended, and the important principle, particularly in extremity sarcomas, is to biopsy through a tract that can be then resected during definitive surgery when possible. The evidence in and this is because of risks for local recurrence, the evidence is not so strong in retroperitoneal sarcoma, but they do tend to avoid transperitoneal approach. And it's essentially recommended in all cases except for certain examples such as well-differentiated retroperitoneal sarcoma, liposarcoma, which is very distinct on imaging. So interestingly, up until the 2017 8th edition of the AGCC Cancer Staging Manual, there was no accepted staging system for genitourinary sarcoma specifically. So I'm not going to touch on retroperitoneal sarcomas and all the staging and everything for those. But this is a broad staging applying to all visceral sarcomas, of course, based on TNM. As I mentioned before, these tumors tend to invade locally. They grow large. They rarely metastasize to lymph nodes, except for specific histologies such as rhabdomyosarcoma. And when they do metastasize, it's typically to lungs and liver. The grading is based on a differentiation mitotic count in tumor necrosis, and in retroperitoneal sarcoma, overall survival is most associated with size and grade and local recurrence with margins. So this is a surgeon's tumor. The standard of care for all localized adult tissue sarcomas is wide excision with negative margins. Because they are so locally invasive, it's often a balance between adequate resection and critical organs and structures. And a key point is that if the final pathology margins are positive, if possible, re-resection is actually strongly recommended. The role of radiotherapy is most established in extremity sarcomas, where decreased local recurrence is pushing limb-preserving surgery. But in retroperitoneal sarcoma, there's evolving evidence that there's decreased local recurrence and increased overall survival. Neoadjuvant administration is favored because it facilitates decreased late complications because the targeting is easier and there's less involvement of normal tissues. The downside to neoadjuvant radiation is increased wound healing complications at the time of eventual surgery. And there's certainly a role for radiation in trying to downstage borderline resectable tumors. But going hand in hand with the point about re-resection, in the context of sarcoma, radiation is not considered compensatory for poor quality resections. So it's not truly salvage treatment. I won't get into management of chemotherapy in the context of palliative chemo, but in the context of neoadjuvant and adjuvant treatment, the evidence is not very clear, and it's, again, case by case. There are specifically known chemosensitive histologies, Rhabdomyosarcoma, Ewing sarcoma, and there are some which may be borderline chemosensitive, as we discussed, myxoid or round cell, and Leiomyosarcoma, but chemo is typically only used if we're trying to downstage a borderline resectable tumor. All these patients should still be referred to medical oncologists, as there are trials open and particularly investigating targeted therapy with TKIs. There's no data regarding optimal follow-up regimen, but the NCCN and ESMO guidelines highlighted a regimen essentially along these lines. So this is just a skeletonized version of all of this, of the NCCN guidelines. As with any malignancy, the first question is it resectable? In only a handful of cases, such as well-differentiated liposarcoma in the retroperitoneum, which are not biopsy initially, and the staging drives any neoadjuvant treatment. After surgery, your margins determine your next steps, and adjuvant treatment is not routinely administered in retroperitoneal sarcoma to R0 and R1 resections, but if you have an R2 resection, you should strongly consider re-resection. And you follow into the surveillance regimen, and if there's a recurrence, essentially the approach parallels the primary local disease, and these tumors do tend to recur, and these are the ones that you see a re-resection of a re-resection of a re-resection occasionally. As the tumor recurs, there is increased use of neoadjuvant and adjuvant therapies. As I won't touch on extrapulmonary metastases, but frequently in isolated resectable pulmonary metastases, particularly those which are metacoronous, metastastectomy is indicated. And here's just the pathway. If your tumor is determined unresectable, you usually give downstaging a chance, but obviously with biopsy first. Okay, so now moving a little bit into the genitourinary sarcomas. So, as I mentioned before, there's this is mainly constricted to case series and epidemiological database studies, and certainly nothing with randomization. This is probably the largest published prospective series. It's from a Memorial Sloan Kettering, and in 2016 they published their 25-year experience. And at that point, at a massive cancer center, they had 131 cases across all anatomic sites within the genitourinary system. The most common were the paratesticular, and then the other major sites, kidney, bladder, prostate, were all approximately equally uncommon. We've already covered the three most common histologies we see, and these are accounted for approximately 75% of cases. And in the genitourinary tract, most of these are presenting as high grade. Interestingly, they had a high rate of metastases at primary presentation for prostate sarcomas. It's unclear why this was. It may have been because they're a very tertiary center, but they also had quite a high incidence of Rhabdomyosarcoma, which does tend to metastasize. And this is from the same study. So the disease-specific survival is generally, it's a worse prognosis than general soft tissue sarcomas. The metastases-free survival was associated with the histology, which is not surprising given what we know about the differential biology and clinical presentation of the different histologies. And importantly, the local recurrence-free survival or recurrence was frequently occurred with metastases, and many patients who recurred ended up dying of disease. This study is quite limited, not only in its numbers, but also they were not able to consider radiotherapy or chemotherapy. And because they're a tertiary center, only 30% of these patients were presenting at initial treatment. So given all of this, it's hard to derive meaningful conclusions apart from getting a sense of what the landscape is like in genitourinary sarcoma, aside perhaps from saying that local control, as with all sarcomas, is particularly important. So I'm just going to touch briefly on renal sarcoma. They're rare amongst, obviously very rare amongst renal cancers. They have a very poor prognosis, amongst the worst prognosis amongst GU sarcomas. And this is probably the largest case series. It's from a group in Sichuan, China. And they reported a very poor prognosis, despite the fact that only a low percentage of their patients actually presented with metastases at initial presentation. And this was corroborated by some SEER database studies as well. An interesting point when it comes to renal sarcoma, however, is that renal cancers are typically the only site we don't routinely biopsy. So sometimes we can be surprised by either a tissue or a mass which is not at the site expected, or a sarcoma in the kidney. We already saw that leiomyosarcoma can be very difficult to differentiate from renal cell carcinoma, can appear quite proximal to the kidney, and can appear with tumor thrombus. I'm not going to get into the details of determining whether structures arise from the kidney, adrenal, or retroperitoneum. That would be a whole talk on radiology, but it's certainly something to consider. And there are a couple quite non-specific signs that are described as possible indications to think of a sarcoma. Location, they typically do arise directly from the capsule or the perisinus area because they are derived from connective tissue, and that's where the most smooth muscle is located with the kidney. Their behavior might indicate or arise suspicion of a sarcoma, particularly rapid growth, large size without nodal involvement. And again, tissue composition can as well, but these are all largely non-specific. MRI can help to delineate, but there's largely no replacement for a biopsy if you're suspicious of a sarcoma. Bladder sarcoma, again, I'm just going to touch very briefly on. It's very rare amongst bladder cancers. The typical presentation is painless gross hematuria in the vast majority of these patients, and unlike urothelial carcinoma, there's a low incidence of tobacco use amongst these patients. As with all sarcomas, the mainstay of treatment is surgery for localized disease, and the role of adjunct treatments is unclear. In this series here, this is from a series at MD Anderson of 19 patients. They did see a trend toward increased disease-specific survival in patients who received a neoadjuvant or adjuvant chemotherapy or radiation therapy, but the numbers and the granulation of the data wasn't sufficient to really pull up anything conclusive from that. These tend to be leiomyosarcomas. They recur distally and metastasize rather than locally, but their prognosis is about average for a genitourinary sarcoma.
Right.
Yes?
What's the role of bladder preserving surgery for this?
So the majority of these are treated with cystectomy, some with pelvic exenteration. There were some cases that were treated with partial cystectomy, but those in the small series, those patients did tend to recur. It'll depend on what the specific histology is, but I think as a rule of thumb, we're more aggressive than we would be even with carcinomas when it comes to sarcoma.
You wouldn't do a partial cystectomy for a sarcoma at the dome? No.
I mean, positive rates are still very high.
Yeah.
And there's positive margins.
Well, what do you know?
But that's one of the main things about surgery sarcoma is wide margins.
Wide margins, yeah.
I think you're even more so than your field carcinoma, you're going to avoid it.
Yeah, exactly. So now touching on the prostate. Again, very low incidence of prostate sarcomas amongst prostate cancers, but prevalence of prostate cancer is a little higher. This is a subset of the data from the MSK experience. So in 2014, so almost 10 years down the road, they looked specifically at all of their prostate sarcomas. The presentation of these patients is typically different from your average prostate adenocarcinoma. These patients are younger. They're often presenting with lower urinary tract, obstructive lower urinary tract symptoms with a very large prostate, but a normal PSA. There's basically an equal divide between leiomyosarcomas and rhabdomyosarcoma. So this is where we see a lot of the genitourinary rhabdomyosarcomas. And again, this is another one where the prognosis is quite poor, and that's likely because of that higher incidence of rhabdomyosarcoma, which is particularly aggressive. Again, surgery is the mainstay of treatment, and in fact, in kind of touching on what the procedure would typically be, in prostate sarcoma, you'd actually usually do a cystoprostatectomy rather than just the radical prostatectomy, sometimes even a pelvic exenteration, depending on how adherent it is to the rectum.
Was there data on, you know that the common treatment here is neoadjuvant radiation?
Yes.
This is a prostatectomy, but is there any data specifically looking at the benefits of neoadjuvant radiation?
Get to that. We're going to get to that in a second. Yeah. So in this trial, they looked at they had inconsistent application of neoadjuvant treatments, and they didn't really look at the outcomes from that. Of note, though, again, this highlights that surgery with wide margins is the mainstay of treatment, as the 43% of those patients did have a durable response, whereas patients with metastases or even limited nodal disease, none of those patients had a durable response. This is another large series. Again, this is from the other group who's sort of accumulating these cases in China, and they essentially saw similar outcomes. They did look at adjunct treatments, chemotherapy and chemoradiation, but it wasn't very finely granulated. They just sort of looked at it in all comers, so it was hard to derive anything meaningful from it. More contemporary cases. So the top series here it's a very small series, but it's from Johns Hopkins, where they're treating these quite aggressively, and basically all localized patients are getting radiotherapy, and a large majority of them are also getting neoadjuvant chemotherapy. And they're reporting much improved cancer-specific survival at 3 years, but I don't know how durable this is going to be, because they have a recurrence-free survival rate of 25%, and none of those were local, so I don't think this is going to be very durable to 5 years, which is what the other studies were measuring. This study by Barry is quite recent, and they looked at SEER data, so they looked at patients with local disease, and they were, I think this was a group of radiation oncologists, and they were specifically looking at the role of chemo radiation in the neoadjuvant setting. And they actually demonstrated quite a significant improvement in overall survival and local control with the administration of these adjuncts, specifically in T3 and T4 disease. So that's these graphs here as well. So there is some evidence. I think the question is still unresolved and, of course, difficult to answer. I think it's driven partially by which histologies you have as well. So the ones that we know from other sites, which might be chemosensitive, as well as the local, whether the mass is resectable on its own. I think sometimes, even if it's not chemosensitive, you end up treating anyway, or radiation sensitive, you end up treating anyway, because it's really your only hope.
Can you comment on the value of lymph node dissection? Are they ever metastasized?
So rhabdomyosarcomas do tend to metastasize to lymph nodes, and rhabdomyosarcomas are much more common in prostate cancer. So I think within prostate cancer, there's certainly a role for the lymph node dissection. I think when they're doing, for example, liposarcomas, I don't know if there's as much of a role for it, but I think in rhabdo there is, and we'll actually look at that in the context of prostate sarcoma, or of paratesticular sarcoma as well. So paratesticular sarcoma, it doesn't refer specifically to sarcomas arising from the testicle. These are actually quite rare. It's more referring to sarcomas arising from the cord, and most are actually diagnosed as palpable inguinal scrotal masses, and a large frequency of these is diagnosed at the time of other inguinal surgery. For example, inguinal hernia repair. The general surgeon might see a large cord lipoma, lop it off, and send it for pathology. So the next series we're going to look at again is a subset of the MSK data, looking at their paratesticular experience. And it's very interesting that 96% of the patients that they saw for paratesticular sarcoma had been treated surgically elsewhere. So this is one that we often discover incidentally at the time of another surgery. And they looked at and they had to make the decision, do they re-resect versus no re-resection? And typically no resection was either in cases that were deemed low risk or where the patient declined. But overall, for paratesticular sarcoma, the prognosis is quite good, at least for sarcoma. But there is still a high recurrence rate, both locally and distally. And this might be because of the higher incidence of liposarcomas in the cord. So these behave a little bit more like the retroperitoneal sarcomas. Perhaps the prognosis is a little bit better because they're in a more superficial space where they're more easily identified, rather than in the retroperitoneum where they're invading into adjacent critical structures. And then here on the bottom, we have their re-resection cases versus their non-re-resection cases. So it's favored towards re-resection for the patients who are high grade, though not much difference. I'm not sure why they didn't end up re-resecting these positive margins, but there was no clear granulation as to whether these were R1 margins versus R2 margins. What's interesting is that a lot of the patients with the rate of positive pathology after re-resection was actually higher than the rate of positive margins on initial resection, indicating we have a lot of false negatives here. And there was clearly a survival or a recurrence benefit, and on the right in the graph here, a trend towards a survival benefit for patients who had a re-resection. This is further corroborated by an even larger series from two large sarcoma centers, one in Italy and one in Birmingham, where their experience was with 82 patients. And all of these had localized disease, 3/4 primary, 1/4 recurrent. And in those centers, they actually re-resect 100% of patients that are referred to them. So I guess they don't trust whoever did the initial resection. And they have excellent outcomes. They have, in their series, they had a 92% disease-specific survival rate. So even better than the previous group. And we see, when we look at, this is SEER data, so this was actually 362 patients. Again, looking at databases, you don't have as granular of information. They overall found, this is a little more contemporary perhaps than the MSK experience, and that's why we have some differences in outcomes. But they had a 92% overall survival rate, and a lot of this is just basically confirming what we saw in those smaller series. What I found interesting was that, so Rhabdomyosarcoma has a 55% node positive rate. So this kind of begs the question, is there a role for retroperitoneal lymph node dissection in these patients? And that's what this group, DANG, that's the question they asked. Their results are a little difficult to interpret because they looked at pediatric patients as well. And as we had said before, rhabdomyosarcoma is a bit of a different beast in pediatric versus adult patients. But when you look at their subgroup of greater than 10 years old, 40% of these patients had positive nodes. And we see on the right here that there was significant improvement in survival with retroperitoneal lymph node dissection in these patients. It also asks the question, what is the role of radiation in these patients? And again, the literature is fairly inconclusive. There's studies on both sides of the argument. As I had suggested initially, the first MSK group, they didn't really favor, their findings did not favor radiation. And a separate group, Kandikar, they looked specifically at liposarcoma, but as we had said earlier, liposarcoma, as we know, is not as often treated with radiation to begin with. The Dang group, who were looking at rhabdomyosarcoma, did find a benefit to known node-positive disease with radiation. And there was a separate group that has a very small series who treated with radiation and claimed no local recurrence. So it's difficult to interpret all these studies. They're all small series. The larger series often have a lot of confounding, and then the SEER and epidemiological studies don't have a lot of granulation to the data. We do see benefit of radiation in other sites, and again, it's often has to be evaluated on a case-by-case basis, keeping in mind the histology and the patient's risk of recurrence from other factors. But I think the important point from the discussion on paratesticular sarcoma, once again, is that surgery trumps radiation in terms of importance, and a re-resection is generally warranted. So lastly, I'd just like to conclude with a case here, and this was the case that made me interested in this topic. So this was a patient who was a 36-year-old young man, Asian, who was previously healthy, had a history of suprapubic discomfort and obstructive lower urinary tract symptoms. He was initially seen while on a vacation in Hong Kong, treated with some antibiotics, but this didn't improve. When he returned, it didn't improve his symptoms. When he returned to BC, his family doctor treated him with ciprofloxacin for a course of 10 days and ordered some initial investigations. Urine culture was negative. PSA was moderately elevated, and ultrasound revealed a 560 cc prostate. Shouldn't have put these all up at once. So he was obviously referred to a urologist in the community. But it was interesting that at the time of assessment by the urologist, his symptoms had largely improved. His PSA was trending downwards. On examination, his prostate was certainly large, but quite smooth. There was no strong family history suggestive of prostate cancer. So the initial thought was that perhaps this is a prostatitis with just a massive inflammatory reaction. So the patient was treated with a prolonged course of Flomax, of ciprofloxacin with the addition of Flomax, and reassessed. And at the time of reassessment, his prostate had actually grown to 700 cc, and he was scoped, which was actually, I didn't have access to the actual note, but from what I garnered, fairly unremarkable aside from a large median lobe. But he was referred to VGH. And at first, it seemed, going back to the notes, it seems that this came across Dr. Patterson's desk as query HOLIP candidate. He was initially referred for a HOLIP, this gentleman, but Dr. Patterson astutely pointed out that this was likely a sarcoma and promptly referred him to Dr. So and arranged for a biopsy and MRI. And so the biopsy showed showed prostatic spindle cells, which is not particularly specific. Spindle cells can be muscle cells, or they can be, as I had discussed a little previously, these specialized prostatic stromal cells. And there was hypercellularity, atypia necrosis, not a high mitotic rate. I unfortunately don't have the original slides for this case. But in conjunction with the staining, this was consistent with prostatic stromal sarcoma. So this just serves to highlight, we talked about all these common histologies, but with sarcoma, you often have quite a grab bag, and this is a separate histology that presents. specifically in the prostate.
So why stroma? I mean,
So it's kind of
is from the stroma.
it's kind of like GIST, right? So you get gastrointestinal stromal tumors. They don't have the same like KIT mutations and all of that like GIST, and I don't think they're known to be imatinib sensitive.
What's the cell origin?
It's like they say prostatic spindle cells, stromal cells, yeah, perhaps.
Are they connected?
Yeah, they're disconnected.
There's the fibroconnective, the tissue around the gland.
But there's
Not enough to say that's a smooth muscle.
It was just a biopsy, I believe, right?
so it was not smooth muscle because it was like smooth muscle actin negative. It was Desmond negative. So it was not a leiomyosarcoma.
These biopsies back in
This would have
No.
It's over a year ago now. Over a year ago, we did have a separate case which was similar to this recently, actually, too, in the last year. And this was involving bilateral prostate from base to mid-gland. And then we got this quite...
So is it just count as a sarcoma?
A GIST, yeah. So a GIST counts as a sarcoma. Yeah, it's treated a little differently. It has different behavior, but when you look at sarcoma, it's included in the sarcomas. I think it's only more recently actually been identified and more appropriately classified. But yeah, it counts as a sarcoma.
It's behavior different.
So what's the difference between sarcoma and mesenchymal? They are all malignant mesenchymal tumors.
Sarcomas. Yeah, exactly. So we have this impressive MRI here. This is 10.5 by 10.5 by 11.5 centimeters here. I think you can see a faint hint of a urethra here. Oh. So this is T2 fat suppression on the left and T2 sagittal, just a regular T2 on the right. It's this hemorrhagic cystic foci. It's encapsulated within the prostate, and there's actually a small area of. This doesn't work very well. On the right side there, or the patient's left, you can see an area where it's come through the capsule, about a 14 millimeter area. So this patient was sent to a sarcoma conference, and the resolution was to treat with neoadjuvant radiation, particularly, as we had said before, because after this was taken out, targeting would be impacted and there would be greater normal tissue impacts and delayed side effects. And then he underwent surgery, cystoprostatectomy with a pelvic lymph node dissection and ileal conduit. And the final pathology was actually quite interesting. So what this was a Phyllodes tumor with spinal cell sarcoma spindle cell sarcoma transformation. So the Phyllodes tumor is analogous to the Phyllodes tumor, which we commonly see, or not commonly see, but which we do see in the breast. This is a stromal tumor, and it falls into this category of stromal tumors of unknown malignant potential. So some of them, they certainly recur commonly, and they've been documented to metastasize, and these, and certainly, as in this case, they can transform into sarcoma. So this is a lesion which has been reported to transform. So it's Phyllodes is within this sort of stump group of tumors. So the tumor was the sarcoma was replacing the outer half of the lower bladder muscle wall, but not invading directly through into the urothelium or into the lumen. The seminal vesicles and vas deferens were uninvolved. Margins were negative. 0 of 18 nodes were positive. And the final histology was was high grade, and this was largely driven by necrosis. And this gentleman's about a year out actually from surgery. He's had 2 follow-up CTs, which have both been negative for any recurrence. But we actually, while I was looking at this, Dave actually sent me a separate case that we did recently as well, and it was a similar tumor. It was a prostatic stromal sarcoma. It was more locally advanced in this patient, and there was actually admixed high-grade adenocarcinoma of the prostate. But this gentleman actually ended up having recently, I looked up what ended up happening to him, liver metastases. So he's been, his goals of care have been changed to palliative, but he likewise underwent cystoprostatectomy. Yeah.
Before I press that, what was the timing on the radiation?
About 6 weeks. Yeah.
How long did you know?
These are always stuck. And this was like the third one amazing in about 5 years. The radiation makes, I think it's stuck, but I don't know if it's actually the radiation versus the tumor or my fear of leaving margins.
Yeah.
So you're always constantly trying to go as far wide as possible, etc. So yeah, and this thing literally, people are like, "Where's the bladder?" I think the bladder is right there, but that was the radius.
Well, this other gentleman who had the prostatic stromal sarcoma, he ended up having to get a ankylostomy as well, because I think it was so close to the rectum that there ended up being rectal injury. Was taken with it. And even for this gentleman, when I look back at the tumor board rounds, there was a question, should we resect part of the rectum because we biopsied through the rectum, right? So that's why even for biopsy, these are important to refer to Sarcoma Conference. So just a couple take-home points. Some of that was sort of parade of histologies and parade of statistics, but in general, all sarcomas should be reviewed at Sarcoma Conference, even the well-differentiated liposarcomas of the cord. Sometimes they don't get referred on. Surgery is, of course, the mainstay of treatment, and you should consider resection for positive margins, and radiation is not considered compensatory for poor quality resection. When we're looking at renal masses, if you're suspicious of a sarcoma, consider biopsy. And as we saw in this gentleman, in a younger patient with obstructive LUTS and a large prostate, he didn't have a normal PSA, but for that size of prostate, perhaps normal-ish PSA, considers sarcoma as a diagnosis. So thank you to my mentors for this project, and I guess we'll have some time for some questions. Oh.